Dr. Brahmbhatt is a board-certified nephrologist and transplant nephrologist. Wow, you are an overachiever. And for those of you who don't know, a nephrologist, if you're seeing a kidney doctor, they're not necessarily trained in transplant. So I have a nephrologist who takes care of me, but if he has a question about my transplant meds, he always refers to my transplant nephrologist. So we got double duty here. She has over 15 years of clinical experience taking care of patients with people who have kidney disease. She has pursued transplant nephrology at Icahn School of Medicine in New York, and then she's been at Thomas Jefferson, and currently she got her medical degree at King's College in London in 2001. So today she is this assistant professor of nephrology. Oh, I'm sorry, I messed that up. Sorry. Let me start over again. She was the director of renal quality improvement, director of peritoneal dialysis, and the director of outpatient hemodialysis unit. She's led multiple quality improvement projects to improve healthcare delivery for patients with kidney disease while concurring having a busy outpatient practice. We know how busy you are. I know how hard it is to get an appointment. She is currently the medical director of practice change at AstraZeneca, where she is committed to improve healthcare delivery for people and their patients who have cardiovascular disease and renal metabolic diseases. So please give a warm round of applause to, did I say your name correct, Dr. Brahmbhatt?
You said it perfectly, Laurie. Thank you.
And I love your accent too. So, well, wonderful. Well, I'm going to turn it over to you.
Yeah, thanks, Laurie, so much for inviting me to chat today. And I love your background, lovely questions and things that, every one of you, I'm sure, has to deal with every day. So, Laurie asked me to talk to you about what keeps a nephrologist up at night, but I felt bad I told her I felt bad talking about what keeps me up at night because the people who are really suffering are patients with chronic kidney disease, right? So you're the ones who are dealing with this disease day in, day out. And, your experiences cannot replace any amount of waking up that I ever had to do. So just a shout out to you for all you fighters. Laurie asked me to talk to you about, things that, usually end up as emergencies. And, the number one thing that kept me up at night was high potassium levels, hyperkalemia. That was, usually the bane of my existence because high potassium levels in patients with advanced chronic kidney disease can go up so quickly. And you may or may not know about this, but if they're, really high, they can be really dangerous for your heart rhythms and they need to be brought down quickly. So there were many nights when the nephrology fellow would call me, or the hospitalist would call me with potassium levels of 7.5, and the patient wouldn't be making any urine. They would be in acute kidney injury, or they would have end-stage renal disease, or they missed their dialysis and their potassium levels would be really high. So, we would have to administer emergency treatment to save that person's life. So we did that quite often. The other thing that kept me up at night was fluid overload. So fluid overload is very common in patients with end-stage renal disease, especially when they don't make any urine, and especially when they're on, dialysis. And so, patients may have missed their dialysis treatments, or they may have had a great party weekend or a vacation, and, we're all human, right? So we all want to enjoy good food and good drinks. And so sometimes, it can be very challenging to live with those fluid restrictions and salt restrictions and potassium restrictions. And unfortunately, patients would come in with difficulty with breathing. or difficulty laying flat, or really high blood pressures and perhaps chest pain, which may or may not all be related to fluid overload, and so they would require emergency dialysis. So that's one thing. And, please, if you have any questions for me, feel free to ask them in the chat. I'm sure somebody can help me navigate the chat while I talk. A few other things that kept me up at night. Ooh, let's see. Oh, yeah. So, as a transplant nephrologist, patients, some patients, many patients were great at taking their transplant meds, right? I feel like the patients who have a transplant, it's very unusual for them to miss their transplant medications on a regular basis, right? They value their not being on dialysis and that type of thing, but unfortunately there were some cases where patients, for reasons out of their control, were not able to take their meds, either that being, losing health insurance, so they couldn't pay for their transplant meds. And so I saw that at Sinai, where patients would come in with acute, well, what we thought was acute kidney injury, but turned out to be, accelerated chronic kidney disease from transplant rejection. And so, doing the biopsy, seeing what the cause was, and trying to save their kidney by giving them medications and that type of thing was always a high stress, but always worth the effort, especially when we were able to save the kidney. I guess the other thing is high blood pressure, right? Patients with, actually, large proportions of the US population have high blood pressure. And, sometimes, there's different thinking, right? So chronic kidney disease can cause high blood pressure. And then in some patients, high blood pressure may be linked to the development of chronic kidney disease. Although some may say that's questionable now, but, it's very difficult sometimes to manage blood pressure in patients with chronic kidney disease because, the kidneys help control the blood pressure. So if the kidneys aren't working so well, the only way to control blood pressure is through medications. And so, the challenge with high blood pressure is that, a lot of people don't feel symptoms when their blood pressure is high, right? So, quite frequently in the office, I would see patients who had, mild to moderate chronic kidney disease with blood pressures that were high, like, 170, 180, sometimes 210. And I would be trying to get those blood pressures down because I was worried that those patients may end up with a heart attack or a stroke with their blood pressures being that high. And, you should always follow your doctor's instructions as to, what your target blood pressure should be. And, be very honest with your doctor. If you're having difficulties taking the meds or have side effects taking the meds, tell your doctor so they can find another treatment for you that works. I have to say that spending more and more time with my patients, you dig up the reasons why the blood pressure is high. I mean, I had a patient who was working 2 jobs and, slept 3 or 4 hours a night, and, on the pill bottles, when the medications are initially prescribed, right? It's like take in the morning, take in the evening with food. And so, his job schedule was such that he was sleeping during the morning, so he would miss his morning meds, and in the evening, he would be working and have no access to taking his medications during his work hours. And so he would miss his medication. So if you figure out the reasons why people may be missing, you can adjust the timing perhaps that works for the patient's lifestyle, and that those kinds of things can help. Okay, so there's a question. How do you remember to take your meds? You know, that's a challenging question. And, you know, there's lots of things that you can do. You have to find something that works for you. You can set a reminder on your phone. You can keep your meds in a place where you're going to see them. You know, you could, you know, it depends on when you have to take your meds too, right? So, you know, if you're able to take them first thing in the morning when you're brushing your teeth, right, you could keep them right next to your toothbrush. If you're taking them with food in the evening, you could keep them on your dinner table. You know, there are reminder alerts and apps and things like that that are available that are free for reminders to take your meds. Although, you know, some people would say, oh gosh, if my alarm was going off all the time, it would definitely set off some anxiety once in a while. But, you know, each to their own. I think, you know, you have to find a way. Even if, you know, even if you improve remembering your meds by 25% compared to what you're doing now, that's still a significant improvement compared to baseline. So do your best. So I guess other things that kept me up at night. Okay, so somebody's saying my phone has alarms set for all the times I need to take meds. It's annoying, but it works for me. Yeah. You know, I think it's always a problem. So here's, you know, something else that kept me up at night was patients who had intractable vomiting or diarrhea. It's a horrible symptom to have to experience. And, you know, it can be devastating, especially for transplant patients who need to keep their meds down, or, you know, if they're sick from infection or that type of thing. You know, dialysis patients also are at risk of infections, right? So if you're on hemodialysis with a catheter, you know, you're at higher risk of bloodstream infections with a catheter in the chest. If you're on peritoneal dialysis, there is a slightly higher risk of peritonitis, which is an infection in the belly, although those types of infections are, you know, usually less common now compared to, you know, 20, 30 years ago, because of the improved techniques we have now. Oh, that's another thing that kept me up at night, actually, was dialysis access, right? So, and many of you may have experienced this yourself when, you know, you go to the dialysis unit and, you know, the needles infiltrate, and then, you know, patients may end up with a hematoma or may not be able to get the needles in to do the dialysis treatment. And then the nurse sends you to the hospital to do your dialysis because, you know, there's no one around to fix your fistula, or your fistula may need rest before the next treatment, but you can't wait another, you know, 2 or 3 days for dialysis. And so, you know, having to put temporary catheters or arrange that, you know, that it always happens outside of hours, and it's horrible for patients to have to go through that. So, Laurie, any other questions?
Yeah, we have a question in the chat. ARBs help decrease protein. Does less protein urine mean increasing kidney function? What number indicate need for a biopsy?
Okay. Yeah, so angiotensin receptor blockers are great medications, you know, just as ACE inhibitors, which are different class, but they do the same thing. They do help decrease protein in the urine. And, you know, in the long term, that helps protect your kidney function. So it can help slow the decline of your kidney function. As well as, you know, there are newer medications as well, in addition to ACEs and ARBs, that can help reduce the protein in the urine, like SGLT2 inhibitors. The number that your creatinine has to go to, or the level of protein that you have that's needed for a kidney biopsy, it's all based on individual patients. So it's really your nephrologist that should be deciding whether a kidney biopsy is warranted. Obviously, it should be a collaborative decision between you and the doctor, but it really depends on the trends of the protein, what the possible causes could be, how quickly the creatinine has gone up, or whether there's any possibility to slow or treat the kidneys from becoming worse in addition to what's already being done. So, nephrologists are always trying to save people's kidneys and to prevent them from being on dialysis, right? So we don't want people to go on dialysis. We're trying to keep them off dialysis for as long as possible so they can live a relatively normal life. And if they need a kidney transplant, the ideal situation would be to go straight from chronic kidney disease to a kidney transplant and skip dialysis altogether. And so the ways that is done is by slowing the decline of kidney function and getting on the transplant list early enough so you can accumulate time. Hopefully you would never need a transplant though.
Well, a question that always comes to my mind is, I have gone to the hospital because I had an emergency. I didn't end up talking to the nephrologist, but it was due to something else. How important is it that you relay to the nephrologist that you are in the hospital?
Yeah, it's pretty important because the kidney is linked to so many other organs in your body, and especially if you have a complex medical history, you never know what could be related to the kidney. However, I also know that it's difficult to get hold of your nephrologist, right? I mean, you may leave like a zillion messages and may not get a call back. You may get a call back, but it's always good to, leave a message and let them know. It's very difficult being a patient and, when you're sick, assessing whether you need to go to the hospital or whether you should wait. I think that, you should follow the guidance of your doctors when it comes to that, for sure.
I know for me that I have had situations where I went into a hospital and because I'm transplanted, and I have to tell people I can't have non-steroidal medication. And they don't understand it sometimes. And so, what I tell them, I say my kidney is allergic to non-steroidal medication, and they get the allergy thing. It's really weird because sadly, a lot of people in healthcare aren't as well versed on kidneys as I believe they should be. We have another question. What does you consider an emergency? It's a broad question, but maybe just put people on the right path. I know for one thing, if I'm throwing up and not getting enough fluids and dehydrated, and I can't keep food down, that would be an example of like, you need to call, because that can be an emergency. You can clot your access if you're really dehydrated. I'll let you continue.
Yeah, I think, so, I'm glad you ended with access, because, if you ever notice that your dialysis access is down, that's an emergency. Even if you're not scheduled for dialysis that day, that's the time that, you should call your nephrologist or the dialysis unit and say, I don't feel any thrill in my fistula. What should I do? Because that needs to be taken care of. Yes, you're right. Intractable vomiting, diarrhea, for sure. I cannot give medical advice. Every single patient is a little different. For example, if you have early stage chronic kidney disease from, diabetes and you're relatively well, and you end up getting a viral infection from your kids, and you end up with a fever of 101, you may not need to call your doctor in the middle of the night. But if you're a transplant patient, or if you have advanced chronic kidney disease, or you have a catheter and you end up with a fever of 101, you probably should call your your nephrologist. So and it also depends on what your doctor has told you that you should call for. I think it's very difficult to give such broad advice as to what an emergency is. I mean, when you call the doctor, there's always an automated message like, if you're having an emergency, call 911. How the hell are you supposed to figure that out? Right. Like I get this chest pain every other day when I'm on dialysis, but today I'm having it when I'm not on dialysis. Is it an emergency? Probably is an emergency if you're having chest pain. That's not normal for you. If you're having shortness of breath, that's not normal for you. You should probably call your doctor,
Well, and it's interesting because I asked my doctor at different times, like, what is the fever that you want me to call you at? What is the blood pressure you want me to call you at? And so I get his buy-in on that. Because you're at different stages. And I know for me, I get UTIs and I don't have any symptoms. So I need to call him if I'm feeling a little cold and tired, and it's not an emergency, I'm preventing one, but I need to go get a urine sample done to make sure that we nip it in the bud. So I'm not keeping him up at night with, I don't feel good. And then I'd like to share this experience because I had a GI bleed. And I did not realize how fast you can lose blood in a GI stool. And this is getting a little, in looking toilet humor, but it's very important. When you look at the toilet, a little bit of blood can be in it and it can look like a lot, but a lot can look like a little. You know what I'm saying? Like, I'm like, oh, it's just a little. And I literally had to get like 11 units of blood from a GI bleed. And it just, I had a bleeding ulcer and I got a little bit of heparin during dialysis. And that's the only, so people need to be very aware and look at the bowl and see what's going on there. And even take a picture of it if you have to, because then you can compare it. Because that's the time that I was really scared. We talked a little bit earlier yesterday about vaccines and, really talk to your doctor about COVID vaccines. I've gotten the COVID vaccine and it's not working for me. So I'm now taking a drug called Evishield, which AstraZeneca does make that, but it's to give me some monoclonal antibodies so that I have some protection. So if I do come in contact with COVID, I have some type of a defense. But I know, and I like this idea Margot put, your Apple Watch that you need to, she can test that out so that she can take her meds. And Gail DeWall said, what can we do to get the word out to healthy people about getting their kidneys checked? I mean,
this is one of the things that, is my pet peeve, right? As a nephrologist, I saw many patients who were diagnosed with chronic kidney disease very late. I think you as patients, you're able to talk to your friends and family. Like, I can talk to you about the guidelines that, there are guidelines that every diabetic, especially with patient with type 2 diabetes, they should get screened with a urine albumin test at least once a year. They should be screened for chronic kidney disease. Our international KDIGO guidelines have other recommendations that every patient with hypertension and diabetes should do that. The challenge is that not all guidelines have those recommendations. Different guidelines have different recommendations, and primary care doctors may follow different guidelines. They don't necessarily follow the KDIGO guidelines. They may not. they may follow the AAFP guidelines or the ACP guidelines and that type of thing. So, there's a lot of work going on with the National Kidney Foundation to increase screening for chronic kidney disease, especially with patients with diabetes. And so hopefully we'll get some national and hopefully international guidelines on that soon.
Well, I have an idea, and I don't know if this is scientific, but in Southern California, we have all these little ankle biter mosquitoes. They never liked me when I was on dialysis and I had kidney problems, but now my creatinine's really good and they love me. So if you're bit by a mosquito, if you're not bit by a mosquito, maybe you need to get your kidneys checked. I don't know. I just thought I'd throw it out there. So,
Lori, that's really funny. That's really
I really actually think they never liked me, but with this transplant, I'm like they chow down on me all the time. And somebody also told me because I have O negative blood, they like me. I don't know if that's valid, but I think that, it makes sense when you have a lot of urea and different chemicals in your bloodstream because your kidneys aren't getting rid of them. It does make you a little bit more tasty to a mosquito. So that can be our new screening, right?
That's a really
somebody said mosquitoes like CO2. Okay, well, that'll be another presentation. We'll talk about how mosquitoes relate to kidney failure. We have one, okay, somebody wrote, you have meds to take every 4 to 6 hours. Half the time you're not awake at 4 a.m. Can it be adjusted when you are awake? Is it recommended to take NSAIDs even if your kidneys have already failed?
Yeah, so these are really great questions. I think if you're taking meds every 4 to 6 hours, please talk to your doctor about changing the meds or changing the schedule of the meds to something that's more amenable to your lifestyle, because they need to understand. They also need to recognize that you're not going to take it. I mean, I'm not going to wake up at 4 a.m. to take a med. I'm sorry. My sleep is really important to me, especially because it's hard to get enough sleep anyway. Please talk to your doctor. There's usually ways around this. I would say 8 to 9 times out of 10, there's ways to adjust your medications. Is it recommended to take NSAIDs even if your kidneys have failed already? Great question. There's a lot of discussion around that lately in the last couple of years, especially because of the opioid epidemic, right? So a lot of patients suffer from pain, and especially kidney patients, they're prescribed opioids generally a little bit more than patients who don't have kidney disease, because kidney disease patients actually do suffer from a little bit more pain. But with the opioid epidemic, everybody's backing off on that and looking at alternative options. So I would definitely speak to your doctor, your nephrologist, about taking NSAIDs if your kidneys have already failed, because that should be a decision between you and your doctor. It's definitely not a contraindication anymore, if that's what I'm saying.
There's another question. What point should a person with decreased kidney function start seeing a nephrologist?
Okay. So, that's a great question. I'm going to tell you, the KDIGO chronic kidney disease guidelines are being updated right now. The new guidelines are going to be published next year. The current guidelines are from 2012, which is 10 years ago. And at that time, they recommended patients should be referred to a nephrologist if your GFR, which is the estimated glomerular filtration rate, is less than 30 ml per minute, which is pretty low. But however, if you have blood in the urine or protein in the urine or high potassium levels or uncontrolled blood pressure, those are also reasons to see a nephrologist.
Well, and I'm just going to give a shout out to kidney doctors right now, because I have witnessed when somebody has had declined kidney function and they go to a nephrologist and they create their kidney cocktail and their kidney stabilizes. You know, because some medications, as you know, are not good for the kidneys, and some doctors don't know that. You know, they're called nephrotoxic.
Yeah.
And I mean, there's certain antibiotics that I shouldn't take. And you know, there's really, they have that specialized training for a reason, guys. And I can't stress it enough. And a great example is my mom was in with acute kidney injury, and the doctor came in and was going to prescribe this antibiotic. I knew it was like an infection. She had a UTI that gave her acute kidney, and she was older. He was going to prescribe an antibiotic that I knew was harmful to the kidneys. And luckily I called a nephrologist who I knew in the area, and he came in that, you know, had rounds there and changed the drug, and her kidneys recovered. So that's the power of it, guys. Knowledge is power. We have a question.
You know, I'd just like to say there's no harm in seeing a nephrologist if you're concerned about your kidneys, even if, you know, you don't meet the numbers and requirements that I just told you were in the guidelines. It's not going to do any harm. They're only going to provide you with advice. I saw lots of patients who were worried about their kidneys, who may have had, you know, other diseases, or, you know, abnormal blood work and no risk factors. So, you know, we're always there to give advice around how to protect your kidneys or prevent your kidneys from getting worse too. Sorry.
Really good. And a diet, you know, they might refer a dietitian to you, which would be the best thing. We had some presentations about a plant-based type of diet with, you know, moderate protein. I think the rules have changed, no more low protein, because people come in where they're malnourished. So it's got to be moderate plant-based protein, I've heard. There's a question, I don't know if you can answer it. What do you think of a 75 to 80-year-old kidney donor wife of the same age CKD patient? Is there any hospital you know where this is possible? I guess she wants to donate a kidney. So I mean, I personally heard of it in some centers.
Yeah.
It just depends. You got to find the right center. It's a different practice.
Yeah, I think that centers that do large numbers of kidney transplants every year may be more willing to take on a slightly higher risk patient. You know, where I worked, you know, there were cases when we took patients, but, you know, it really depends on the individual patient, right? You know, it's not always possible.
Yes.
We don't want to do any harm.
Right. You got to make sure that, you know, that's the one thing. One of the persons that was going to donate a kidney to me, they found serious health issues with them, and them wanting to donate a kidney to me saved their life. So, you know, I always tell my husband that, you know, I am the most well-monitored person in the world. Nothing's ever going to surprise me that catches me with some illness I didn't know I had, you know. It's so true. I think we have, somebody had a question. I mean, why do they show a different number of, for African Americans? I think that they're, I mean, I could answer this, but you could too.
What is this referring to?
Well, I think in the community they refer to African Americans. They pull out the data a lot of times, and I think because
the GFR, they're talking about the GFR. Yeah. So you know, this is a hot topic now in the nephrology community. Many of you may already be aware that the American Society of Nephrology and the National Kidney Foundation work together to figure out the most accurate way to measure GFR in patients. There is now a new race-free GFR equation, which has been validated by many computational models to be very accurate. So, you know, you can ask your doctors to measure the race-free GFR equation. Your lab may or may not be doing it yet, because it's a relatively new equation. You know, the reasons why there was a different EGFR for African Americans is a very long story. And, you know, a lot of the things may be inaccurate at the time that, you know, or misinterpreted or whatever. I mean, there was, you know, there was valid data at the time that was thought to be valid at the time when these EGFR equations were designed. It's not just African Americans where, you know, EGFR may be not so accurate, right? So, you know, most of these equations assume that everybody is 1.73 meters squared in size, you know, the MDRD equation. But, you know, in somebody who's much smaller, the EGFR estimation may be, you know, inaccurate when it's reported on the lab versus somebody who's much larger. So there's a lot of, you know, a lot of nuances that go into that.
That's excellent. There was a comment by somebody that said John Hopkins transplanted a mid 80-year-old kidney into a mid 80-year-old recipient, I believe, family. So I think that's really wonderful. You know, it's a medical practice, everyone. We're going to be launching a transplant dashboard that will help people understand a little bit more about some of the different centers and how many kidneys they perform, because I think people need to know that if there's this transplant center that's only doing like 10 transplants a year, that may not be the center who wants to go out on a limb. And it's not a limb, it's just do something different. And then secondly, I think that you know, everybody needs to talk to their own doctor and really understand what's right for them, because we're not giving, you know, we're just giving suggestions here. And I think, are there any other questions in the chat? I mean, you did it. Oh, is that?
So I saw one about how do you find out where you're on your transplant list?
Oh.
And so, you know, the way to find that out is to call your transplant center. You should have a transplant coordinator at your transplant center who should be able to tell you.
It is, you know, it's crazy because you always got to be ready, guys, because how kidney transplants work at a center, you may be like the second or third backup because the kidney will arrive at a center and then the first person in line can't get it. And then sometimes it can go to the second or third. In my case, I was only on the transplant list for a year and got a call for a perfect match. And so there is some, you know, you need to be aware of this, but in different parts of the country, there's different wait times. And then you can multi-list. And I encourage everybody to come to our support group and you can learn more about that. We'll tell you all the different ways and all the different aspects. So, well, thank you so much, Dr. Brahmbhatt. This was wonderful. And I'm going to bring Cher up here when she can to, but I appreciate your education and effort, and I love your accent. So you have a delightful voice, which makes things even better.
Well, I really appreciate you having me, and thank you so much. It was a real privilege to be on the call today.
And a shout out to our corporate mission partners for making this happen.